Okay, the meeting is now recorded, and I'll go ahead and start your September meeting. There are a couple people who are still trying to join, and so I'm going to be mildly distracted trying to admit them. But Damian, I don't know what your schedule is like this evening or how long you can stay. So before I start the meeting, could you introduce yourself to the Hope Board and let folks know your new role?
Sure. So my name is Damian Sands. I'm the new Behavioral Health Director for Benton County. And I'm having technical difficulties myself. That's why I'm calling in. So during this, I'm going to see if I can't share my meeting with myself, so if you see another phone with another name showing up on your admit, it's probably me, just so I can see maybe folks or the presentation. So I'm going to try some technical wizardry, down the road. Anyway, so I wish I could see everyone, but it's lovely to meet you all, and I know we'll be talking more in the future. Okay.
Thank you, Damian. And the meetings are open to the public, so any phone number that joins is welcome. I'll go ahead and start screen sharing and start your meeting for you all, just so we can get through an overview of the agenda. Can I also ask if folks are not actively sharing and speaking, if you could please mute yourself? I think when you, sorry, let me move this out of the way. Here we go, slideshow. When you join, I believe you are not muted. Okay. Paula, can you give me a verbal, you can see the slideshow?
Yes, I can see the slideshow.
Great, thank you so much. Okay, to kick off your meeting, just some housekeeping to please mute until you're sharing. You can share your visual, your video by pressing camera at the top of your screen. And for public comment, type into the chat area with your name and that you want to make a public comment in the general topic of it. And then for those on the phone, I'll pause to make sure you have an opportunity for public comment as well after we go over the agenda. So here's what you're covering today. The educational component, I'm excited to round out the information about all the different types of services and service centers we have in Benton County and also Linn County. So we'll introduce your guest speakers shortly. Then we have some wonderful community updates from Hope Board members and from the city and the county and CSC. And then there will be a discussion and hopefully an update about the role that the Hope Board can play for community engagement for the City of Corvallis Social Services Funding Policy. And then we have some upcoming meetings where there will be a date change in November and December. Just a reminder about the agreements that you all wanted to set for the culture of the Hope Board for folks who are joining for the first time, and just a reminder for people who know it well. Okay, I will go ahead and stop screen sharing and see if there is anyone who would like to make a public comment. I'm not seeing anything in the chat, but let me double check. Are there any folks who have called in who would like to make a public comment today? Okay, seeing none in the chat or on the phone, going once, going twice. No public comment today. All right, I'll go ahead and share again. So the vote to approve your August 2022 minutes, I sent them out, I believe on Monday, or maybe it was last Friday. I didn't receive any edits. I looked at them myself as well. So we will go through, give me just a sec. I see someone in the lobby making sure they can get in. Paula, are you still seeing my screen? Great, okay, thank you. So are there any other changes that the board would like to make to your minutes from your last meeting? Okay, hearing none, I entertain a motion to approve them, and we'll go through and call roll while you approve them.
I make a motion. This is Andrea.
To approve them. Charles seconds.
Motion to approve that.
Thank you both. Okay, we will go through and call roll. And you can say here and yay or nay or yes or no, and please abstain if you were not at last month's meeting. Catherine Biscoe. No, I did not see her here. Carol Butcher, I know cannot make it tonight. She has an excused absence that I learned about just before the meeting. Ricardo?
I wasn't in the last meeting.
Okay, no problem. So you're here and you abstain from the minutes?
I abstained from the minutes.
Thank you. Brian?
Here and approved.
Thanks, Brian. Cade will not be joining us tonight. They are excused. Anita is also excused. Joel?
Here and approved.
Thanks. George, were you able to join?
Yes, we're here and
Great.
approved.
Great, thank you. Ari? Is Ari here yet? I know he has to leave early because of back to school night, the first one he's been able to attend in 3 years. So it might be that he had to miss the whole meeting. If so, his absence is excused. He let me know ahead of time. Barbara?
Here and approved.
Thank you. Melissa?
Here and approved.
Bria? I haven't seen Bria yet. Cindy?
Here and approved.
Charles?
Here and I approve.
Peggy?
Here and approve.
Andrea?
Here and approve.
Jan?
Here and I was absent.
Chanel?
Here and abstain.
Thanks. Nancy?
Here and abstain.
Okay, thank you. Your minutes are passed. I'm going to stop screen sharing just for 1 second to give you an update. If this will let me, give me just a sec. Reese Stotzenberg is no longer able to be on the Hope Advisory Board. He's doing a ton professionally and personally. And he wanted me to send his best and his thanks, and he has loved being on this board for the past almost 3 years, and now he's going to tend to his family and his business, and to helping with Harriet's housing. And so I wished him the best of luck, but if any of you cross paths with him and want to thank him, he's no longer going to be a Hope Board member, so I'm sad to see him go. Wanted to be sure to share that. All right, I will go ahead and share just to introduce our fantastic guest speakers tonight. We have folks here from the Community Health Centers of Benton and Linn counties. We call them the CHCs for short. And one of the main questions that the Hope Board members have posed is how do our CHCs serve our community? How does that service intersect with the topic of homelessness? And so we have 2 wonderful guest speakers here tonight, and I will go ahead and let you introduce yourselves and you can talk about your role. So Carla, I'll pass it to you first, and then Dr. Michek.
Great. Thank you for having us tonight. I have to start by apologizing. I had a conference in Portland, and so I'm in a large room and might have a lot of background noise, so please be patient. So I'm excited to be here. I think I have a lot of respect for this board. You have a very complex charge ahead of you. And I think Dr. Michek and I are excited to be able to share our services and give you more information about the community health centers and how we might fit into the puzzle as you're continuing to move really, great changes forward. So with that, I will one more thing. So I'll start the presentation, Julie, and then I'll hand it to Dr. Michek, and then it'll come back to me to finish it up. So with that, I will hand it over to the wonderful Dr. Michek.
I don't know that I have much more to say. I've been told I'm wonderful about 5 times now, so I don't know. Hello, everybody. I am Jennifer Michek. I am an osteopathic physician, a DO, and a primary care provider at Benton County Health Community Health Services centers. And I have been at the Benton County and Benton and Linn County's community health centers for 7 years now, and came here to start our complex care program, which we'll talk more about. Also here, invited her along is Jessica Delapine, our team case manager, and so she'll be helping out probably maybe with a little bit of the information as we highlight one of our patients that illustrates a lot of what we do. So Jessica is here too.
Okay. So I guess, do you want to make me the presenter, Julie, and we can get started?
You should be able to just dive in and share. There's no permissions, so you click on the share button in the top right, and then you choose applications, and you can choose which application you want to share.
Okay.
Julie, just a reminder, that's only if you have Teams installed. If you're doing it from a browser, it's at the bottom of your screen.
Okay, Charles, thank you. It's at the bottom of your screen, Carla, unless you're on Teams.
I think let me know if this works.
No problem.
Did that work?
Yes, go ahead and put it in slideshow mode and we'll see it big, and that's perfect.
Okay, well, we already went ahead and did introductions. So thank you again for having us. We're here to talk about the supports that we have in our communities in both Benton and Linn counties. And we'll be highlighting a lot of the work specifically that our providers and our care teams are giving to, treating our patients in our community specific to.
And Carla, can I interject and ask that you put it in slideshow mode, because it'll make it a lot bigger for everybody who's looking.
Oh, it is on my screen, so let me try to figure this out.
We can see the PowerPoint, and you're on slide 2. There we go. Perfect. Now it's working.
Is that better? Okay.
Thank you.
All right. Okay. So the plan for today is we will, it'll start with myself. I should have introduced myself. I'm the executive director of the community health centers of Benton and Linn counties. I work side by side with Suzanne Hoffman, who is the health department director. And then, and we run 6 clinics across Benton and Linn counties. The plan today is to kind of just be able to educate and showcase the work that's being done to support, the most medically underserved vulnerable populations within the 2 communities that we're serving. We'll go a little bit over who we are, what we do, and where we go from here. I won't spend as much time talking today as I will allow for Dr. Michek, because I think what you're all really looking forward to is how we're handling how are we providing access to services for the populations in need, so in the most need. Who we are. We are one of 1,400 community health centers across the nation. We have six primary care locations, clinics, and then we have a plethora of other services and locations that are more support services across our communities. But the main scope for today is that integrated primary care clinics, and we have 6 locations. Community health centers are nonprofit, patient-centered governed organizations that provide high-quality, comprehensive primary health care to America's most medically underserved communities, serving all patients regardless of income or insurance status. And if we break down patients across the nation who are enrolled in community health centers, you can see kind of the divide in the type of insurance or low income or minority groups that are being served specifically by community health centers. This slide is just a way to represent that one of the reasons we're grant funded is to make sure that we are meeting people where they need to be met. And we're looking at some of those populations that don't access healthcare in the most traditional way. And so how do we think more creatively, and how do we make sure that people who deserve social services and healthcare services, how are we making sure as a community health center they're getting those services? So you can see the numbers here in specific populations across the nation and how community health centers are serving those populations. We see our preferences to make sure that we're engaging with people in a way that's equitable as veterans, school-based health center patients, agricultural worker patients, patients best served in a language other than English, and patients experiencing homelessness. The public housing patients, that is a population for which our community health center isn't specifically providing services for, just because we don't have a lot of patients in our area. But there are other community health centers across the nation who do serve public housing patients. The reason we're able to do the work that we do is because, one, federal, state, and local funding supports. We're primarily grant funded in order to make sure that people without insurance are able to seek the services that are due to them. We receive grants under the Health Center program, which is sits under the Federal Health and Human Services program. We are under the department called HRSA, and we receive a large grant fund from them every year. It's a 3-year application where we're able to continue to provide a sliding fee schedule to patients and see patients regardless of their ability to pay. And then our second largest funding stream is our CCO payments and other insurance payments and state Medicaid. So we have this includes value-based payments where we get paid differently from our CCO partners and the state to make sure we're able to provide that care team approach and that patient-centered approach with a robust care team. We also are eligible for smaller grants to do projects and such as the work that we did with COVID, the work that we're doing in our agricultural migrant farm worker populations and those locations, and then just innovative projects. And then we sometimes are eligible for some county supports as it relates to mostly like our facilities and such. This is a graphic to show you who we are insofar as where we sit in Benton County. So the community health centers of Benton and Linn County are actually a department within Benton County, and that department is referred to as Health Services, Benton County Health Services. And this chart, really what it does is we call it a rainbow chart, and it shares with you how on the right side or the left side of your screen, you have these person-centered services, and that's specifically what community health centers are providing. That's your primary care in the different clinic sites, dental care, addiction services, specialty behavioral health. And then as you cross the spectrum, those are shared services, and that both the community health center and the health department, which is on the right side, the population-centered services, those are health department services. So even though we're separate under the health center umbrella and the health department umbrella, we have a lot of shared services. And so we call this kind of our rainbow chart, where it really displays how we all work together for community health. The community health centers specifically have, like I said, 6 location sites where we're providing primary care. Just to quickly kind of share a little bit about who we serve, we are in LC at the LC Health Center. In our population that we serve, there's about 165 patients. We also work closely with the school there, even though we are not a school-based health center because there's rules around you having to be on site. But our clinic is directly across the street from the LC school. So we are in partnership with the LC school. We serve, obviously our primary spot is Benton Health Center there on 27th Street by Shintimony, kind of on campus. And then at East Linn Health Center, we have a clinic in Lebanon where we rent it. Actually, we are basically asked to come there. We stay in a Samaritan building and serve the population there that's most in need and can't afford health insurance. And then we have a site at Lincoln Health Center where we're a school-based health center on the Lincoln Elementary School campus in Southtown Corvallis. We serve the Monroe Health Center. That one is a lot of actually Lane County residents just because it borders Lane County and is also in Benton County. And then we're also on the school grounds and are a school-based health center there in Monroe. And then in Sweet Home, we have a clinic where we share the same building as Linn County behavioral health. And so we're able to kind of integrate a little bit with Linn County in providing primary care services in Sweet Home to serve the most underserved populations in Sweet Home. We also provide dental services. So Benton Health Center has a full adult outpatient restoration and treatment clinic. And then we have a clinic at the Boys and Girls Club of Corvallis where we see pediatrics. We're also offering services at the Lebanon Veterans Affairs, Lebanon Veterans program, where we go to facilities there and do preventive care. And we're also in all of the schools doing our sealant programs and lots of different outside events in the community.
Hey, Carla, can I just jump in? Because I have heard a misconception here in Corvallis that one of the only places folks could find dental care for free or if they're uninsured was over at COI. And COI does great work. But I am really thrilled that you included this slide on dental care so that people know there are multiple ways to access dental care through our community health centers. Also for folks who are uninsured, underinsured, without documentation. So thank you for that last slide.
Yeah, I will say there's a big demand and there is quite a wait list like most services. I'm sure everybody is, this is a common theme, but yeah, there is. And we work closely with COI too and usually get referrals. Yeah, thanks, Julie. All right, a little bit about our populations that are currently seeing our clinics, our clinic providers. This is as of August. Our panel size, so that means patients who have one of our primary care providers across those 6 clinics. We have a panel size of a little under 8,400 patients. We see that fluctuate up to 9,500, just depending on what the times are like, what the demand is. But in order for us to have a full panel, that would be 14,000 patients. So we have a lot of access available. There's a lot of breakdown information in here, and I can share these slides with you at the end. I would just highlight a couple of areas. One is the co-occurring conditions. So 25% of our population has co-occurring medical conditions. And then the other thing I would share with you is our preferred language other than English. 23% of our population has a different preferred language. And then even though we have 8,373 patients at this time, based on whatever provider that the patient sees in our clinic, whether that be the provider, a behaviorist, a behavioral health outpatient treatment provider, the dentist, our numbers, we have about 38,000 visits per year. Oh, one more thing I would highlight is our average visits per year, per patient per year is 4.5. So that's not, I don't know what the standard is right now or what the average is, but typically if you think about yourself, or your family members, you probably go to the doctor maybe once, maybe twice a year. The patients we see 4.5 average. A little bit about our poverty level, our insurance status, racial ethnic identities specific to our community health centers. So overall, 44% of our patients qualify to be at 100% of the federal poverty limit. So almost 50% of the patients we see qualify for $0 charge. 60% of our patients are less than or equal to 150% federal poverty limit. And then I haven't looked at the number recently, but the last time I did, it was 77% of our patients are at 200% of the federal poverty limit. 34% of our patients identify as members of racial or ethnic minority groups. And then that's 2 times greater than those who identify this way in local communities. And then in Benton, there's a breakout there of Benton County and Linn County. So what do we do? Our mission is to make sure that the most vulnerable populations in our communities are getting access to services, because everybody deserves to have social, physical, wraparound services no matter what. And so our mission is healthy people, strong communities. We provide physical health care at our primary care clinics, but we integrate that with a behaviorist. So we have a behaviorist on that care team. We have clinical pharmacists who come in and help people with their medication management. And then we have a clinical health navigator on each one of our care teams that help people with community connections, insurance, peer supports, help people with social services, help people with education regarding their condition. And a lot of it is, most of our clinical health navigators are bilingual to help with the language barrier as well. We also have behavioral health care integrated into our care teams, and then of course our dental health. And then this is kind of my transition slide to hand it over to Dr. Michek. So in each one of our care teams and our clinics, you know, and as you're all seeing in our communities, an increase in the demand for the need for substance use disorder treatment and therapy. HRSA, this is a slide that kind of just shares with you what the community health centers in the nation have been doing in order to help with addiction and access to services for people suffering from addictions. Health centers have tripled their behavioral health staff over the past 10 years. Health center providers performed evidence-based screening, so experts for almost 13 million patients in 2020. There are 8,400 health center physicians, certified NPs, and physician assistants authorized to provide MAT for medication-assisted treatment for opioid addiction. And we have several providers who have their waiver to provide MAT services, Dr. Michek being one of them. And then nearly 182,000 patients received medication-assisted treatment for opioid use disorder in 2020 from a CHC. So that is my last slide before I come back to kind of finish us off. For the next portion, like I said, Dr. Michek, I'm pleased to have her be able to share with you what we're doing with another service array that sits within our primary care clinic location at 27th Street. But it really is different than just primary care services. It's this complex care program that she has been able to develop, and we've learned a lot from, and I'm excited for her to showcase complex care. So with that, Dr. Michek, I can either be your slide person, or I can stop sharing and you can share. What would you prefer?
We can't hear you yet, Dr. Michek, if you're trying to talk.
Sorry, forgot to unmute. Yeah, Carla, you can go ahead and just do the slides. That would be fabulous since they're already ready there. So complex care is a developing, I don't know, it's not an official specialty. You can't get board certified in complex care, but certainly a developing way to approach care for patients who have the most complicated medical, social, behavioral needs that end up being the highest utilizers of the healthcare system. And so 7 years ago, the community health centers started a complex care program. And our team currently is 3 strong and mighty people here. You see us, that's the 3 of us. That's myself in the middle. And on the left is Jessica. She's our case manager. And on the right is Kathy Collins. She is our medical assistant. And so that's our team. This is a picture. We were just at the National Complex Care Conference last week. So that's our picture from conference. We work with many different departments and coordinate care with many, many different teams, not only, as you can see on the slide here, teams that we have within the community health centers and our mental health, behavioral health services, but also with community partners as well. So next slide, if you would, Carla. So this slide it looks just like the one you saw a little bit ago that Carla showed. That was for all of our community health center patients. This is just for the complex care patients. We have our goal of serving 150 patients, and we're actually 152 as of this count. And a couple other things just to highlight compared to the previous slide that we saw, the co-occurring conditions, meaning, you know, they have multiple medical problems. In our panel is 43%, and you may recall it was 25% in general for our patients. So almost twice as many. And then our average number of visits per year is about double what it is generally. You can see there 10.3 visits per year on average per patient, and it was 4.5. So this is like, a kind of a snapshot of our patients in general, but I want to pause here and talk a little bit about one of our patients and kind of give you the story and weave this story within our slides. So to kind of give, a personalization to what we do. So I'm going to talk a little bit about Joe. Joe is a 57-year-old gentleman who became my patient just shortly after I started here 7 years ago. And he became my patient through the outreach of our public health nurse who had identified him as having someone with latent tuberculosis, and he needed treatment for that and needed a physician in order to monitor that treatment. And that's a very hands-on, they meet with the person daily and give them medication every day. So he interacted with us, did the appropriate things, primarily with the high intensity of that public health nurse to complete his treatment, and then didn't see much of him from around November of 2015 when he completed his treatment for latent TB, and then became active again in our care in March of 2018 when he, I'm sorry, what was that? Okay. And at that time, he had recently, or he had learned about 6 months prior that he had diabetes. So he was admitted to the hospital with very severe, evidence of diabetes, and so then he needed to get back into care. So this was kind
Dr.
of a big
Michek,
thing
I'm
for
just
him.
going to interject and ask if any folks are not muted to please go ahead and mute yourself. I'm trying to see. Here we go. I will go ahead and mute the participant. Apologies, Dr. Michek, continue.
No problem at all. So one of the challenges that Joe has faced for many years now is being houseless. And so as a person with, pretty out of control diabetes at diagnosis, needing to be on insulin right off the bat, and how to navigate that when you're not sure where you're sleeping tonight. So, so it was a pretty complicated thing. So I think we'll go to the next slide from here. Carla, if you want to go ahead. Okay. So what our team offers, so we are a small team. They know exactly who we are. Each of us, they have the relationships with each of us, and they contact our team members directly, either through Kathy or through Jessica. They will also have each of them have a cell phone that the patients can text to contact. So they don't do the press 1 for this and 2 for that and 3 for that, that, every office just has to have in order to manage the call volume. But they just have a direct line. So as we already said, they see us 10 times a year on average. We are mobile and are willing to do visits anywhere that we need to. So most of our visits are done in the clinic in Corvallis, but you can see since January of 2020, we really started to increase our visits that were done offsite. And we've done them in people's homes, of course, but also I think our most unique one was, I think, the corner of 3rd and Monroe. We did a visit there, checked, just the whole thing, vital signs and everything. That's where the patient wanted to be seen. So we're willing to go wherever. We keep telling our harm reduction team to take us to the camp. We're ready. We got our boots. We're good to go. So to illustrate this, one of the places we have most successfully been able to see Joe is at the Men's Unity Shelter in Southtown Corvallis. Him getting into the clinic for visits was just not really working out. And especially when the shelter became more available year round, it was working pretty well to stop in the morning and here we are, Joe. We tell him ahead of time. He wouldn't always remember that we were coming. But then we'd have our visit there at the shelter. And that was where we've connected with him most consistently and been able to do most of the work we've been able to do with him. So go ahead, next one. So ER visits. So one of the ways we've been able to demonstrate good outcomes with our complex care, we've looked at the data a couple of different ways, and this is one easier way, excuse me, to look at it. So if we've had a person on our team for at least 2 years, 75% of those patients had fewer ER visits the second year compared to the first year they were with us. So the longer they're with us, the less they go to the emergency room. And of those patients, it reduced about 23%. So some pretty significant impact. And this is illustrated well, actually, with Joe. I tried to count up his number of ER visits and I kind of got lost, but I was able to narrow it down a little bit. In 2020, he had 1 hospital admission and 12 ER visits in 2020. Previous years, it was actually a lot more. And then in 2021, he had 15 ER visits. And then in 2022, his last ER visit was in January. So he has had no ER visits since January of 2022. So pretty exciting as far as that goes. Go ahead, Carla. You can go ahead. This is just a little look at some health impact metrics. We definitely have patients with diabetes, Joe being one of them. And you can see that us being in the green, that we have about 74% of our patients with diabetes at control based, what that's defined as by a certain lab value. So it's a little bit more than general. And then our blood pressure control for our patients is about the same as the, really great work we actually do as a community health center and completely. So we have complicated patients and we're still able to, for many of them, have their healthcare conditions be well managed. So yay for us and them. Next one. Now, I should say though, for diabetes, that isn't actually the case very well with Joe. His last A1C, which is the measure of diabetes control, is not at that goal. So we have work to do with Joe as far as that goes. So many of patients are doing well. Joe, it does not happen to be one of them at this time. So we'll keep working with him on that. So next one, Carla. So definitely as people have gotten to know a little bit more about our program in the community, we've gotten not only internal referrals, we've gotten community referrals. Over the last couple of years, our panel size has continued to increase. We're actually over our goal right now, and we're busy. We're definitely busy. We're feeling it. And just that the demand definitely outweighs the supply of our resources right now. So next slide. So you guys can read this a little bit. I did highlight and made bold a couple of phrases that jumped out at me on these couple of patient feedback snippets here. And these are 2 aspects that these patients are expressing that I think really makes our care work. And the benefits that our patients are really able to see. And that's something called relationship powered care. And we work hard to develop good relationships and good rapport with our patients. Many of them have distrust of the medical system, have not had good experiences with the medical system. And so we really work to develop those relationships. And then I think that's where we can start from to really develop good outcomes. So those are like the warm and happy warm fuzzies going on. And a little bit more warm fuzzies, but some challenges are illustrated with Joe. So Jessica joined our team, and I want to say it was 2019. Yes, Jess?
2019, right before the pandemic, yeah.
Right before the pandemic, yeah, Jess. So, sorry. So we didn't have a case manager before that, and we really recognized that there's so many aspects of health, as you all know very, very well, especially as you focus on difficulties with having housing that affect health, and those weren't things we were able to address. And so we were able to get some grant funding. Jessica's position is entirely grant funded ongoing through HRSA, so her salary is ongoing, covered forever. Thank goodness for that. And she joined us to really look at all those other things that are going on with people that impact their ability to manage their health or be healthy. And so she started right off the bat working with Joe very intensely. I found out that Jessica has had 157 visits with Joe in the time that she's been working with him, visits or interactions or work that she's done on his behalf. And she's documented all 157 of those in the chart. And couple of things. So even having to connect with Joe in this, kind of up in the air system sometimes, she has been able to get him, and he now has disability, so he has an income, and also has been able to secure a housing voucher for him, and he's like this close to he could get housing. He could get housing. He just needs to apply for choose a place he wants to apply and apply. All of Jessica's visits are not billable because of how this funding structure is. Joe would have to, with Joe, not other visits with other patients, but with Joe in particular, none of those visits are billable because he would need to engage with a certain type of mental health person in order for Jessica to be able to bill those visits, and that's not just something that Joe has been up for and willing to do. So that's been a tough thing. It's just a reality, and just want you all to understand that there's limitations in our funding and our ability to work sometimes. And then there's challenges though. So Joe, is a success story in so many ways. He's this close to having housing. He's got an income now, but recently, and I don't know that any of us can quite figure this out, but Joe has not been connecting with us in the usual way. We say, hey, we're going to come down. We'll see you at the shelter. He says, okay. When we get to the shelter, he has left. So his behavior is expressing ambivalence around something, and we're trying to figure that out. Our next step might be to go, connect with him in the community, another place that, our harm reduction team is great about saying, hey, we think, they know their people and Joe could be here. Maybe we can go connect with him here. But we have to have our resources and time. And we one time went to go see Joe at the shelter and he had left by the time we got there, even though we had just talked to him 20 minutes before, said he would stay. We drove around for about an hour trying to find Joe, didn't find him. So I don't know if there's anything else you want, but that illustrates the amazing work that, and I really should say just the team is just amazing. I do the easy part, really. I do the easy part. Jessica and Kathy are both just incredible people who do very good work. So a lot of good things happen with our team, as you've seen. We have challenges. And one of the big challenges is the demand is huge and there's so much more we could do. But there's just 3 of us, so we need more of us. So anything else you want to add, Jess, to that?
Yeah, thank you, Mitek. You provided a really helpful picture. I just wanted to add that from not just from this individual, but from others who I've worked with who were originally unhoused and later experienced what it's like to be housed, there was a tremendous struggle with that change in lifestyle. There's definitely, I wouldn't be surprised if Joe has a fear of being housed. And so I know one of the parts, one of the services I provide is, so I have been successful in helping folks keep housing by addressing that lifestyle change, and it's just very, very, very isolating.
Jessica, can I intervene for a sec and ask if you can pull your mic a little bit away from your mouth? We're getting some feedback. Thank you. And Carla, no, that's fine. And Dr. Mitek, if you're done slide sharing, if we could stop slide sharing so we can see you all a little better. I know that Dr. Mitek needs to leave right before 5. So are you ready for questions now? Or Jessica, did you want to dive into more about your role?
I think it's pretty self-explanatory. My role is specifically is to help folks address the whole person, the whole health of the person. And so we're not just focusing on their physical health. We're also addressing their behavioral health, their mental well-being. We're also addressing all those other factors, social health wise. And so, I mean, I work very closely with Deb Northwest and helping them with their finances. I mean, that's just one example. I mean, I could go on and on and on, but this is definitely, I kind of just surprise showed up to be a part of this. So I can, yeah, I'll just kind of end it at that unless anyone has questions.
Can I ask a question? Because Dr. Michek said, "Oh, great, this person finally has a voucher." It is so hard to find a place and go through the process of a voucher. Is that also part of your role to do that housing connection and navigation?
Oh yeah, I've gained a lot of experience on helping folks get vouchers and use their vouchers and successfully get housed. It's been beautiful, and then also even being able to help them build that home. And it's so rewarding. However, it's also very it can be frustrating at times when you're in that time crunch of like, okay, the voucher is about to expire. What do we do? And so I try to work around the system and try to keep I'm all about finding those opportunities that can be so hard to find, and so we've been successful in keeping his voucher going until he's ready, and so it's all about just trying to keep it available for him until he's ready.
Thank you. We've got a question from one of the board members, Melissa Zavorin. Go for it.
Yeah, hi. Thank you so much for your presentation. I love community health centers. Such an integral set of services they provide, really. So Jessica, I was thinking about, payment for your types of services. So what qualifications do you have? I think I might have missed that.
Yeah,
What type of, sorry.
It's a qualified mental health associate.
Oh,
So
okay.
I have a bachelor's degree, and in order for me to be able to bill for my services, I have to go off of a treatment plan that is specifically has
Mhm.
been created by a qualified mental health professional. So that would be someone like a
Right.
licensed counselor. Yeah. Okay. So.
Yeah, I'm familiar with those classifications. So, yep. Okay, thank
If
you.
if I could actually just add to that payment question a little bit more. So part of the reason that we're not able to actually we're basically, Dr. Michek's panel right now is basically closed. And the reason that it's basically closed is we're at this place of looking and trying to evaluate how we continue to sustain it. So we're using, a portion of our grant funds to be able to do that. But that's not all that our grant funds, that's not what specifically our grant funds are needing to be used for in order to support these patients. And the care that this team is providing is really specialty medicine. It's above and beyond primary care, and it takes a group of people who are out there doing this work in a non-billable service way. And so I think that what I wanted to do and finish this is just to say, we work with our federal, state government agencies, we work with our partners in the community, and whether those are community-based partners or, the other healthcare industries like Samaritan and our CCO and the clinic. But really what I would like to do, I know I was asked here to provide education with Dr. Michek and Jessica, but I would also like to ask, and that's just to think about how we could be thought of in the role, in our role as you're all charged with trying to put to these principles into place, and how this type of specialty service might make sense for preventing houselessness and ending houselessness for all. And if that's the case, how do we advocate for the funding across these community partners and federal and state entities to continue to support it?
Well said, Carla. Melissa, did you want to chime back in on that?
I think Barbara had her hand up before me, but I guess because it's a follow-up, I'll just kind of chime in and say that I think there are good possible avenues, especially as, OHA is really looking at spending more and investing more in social determinants of health. They do have a category of service called in lieu of services. They have to identify what those in lieu of services are, and this would fit right into that bucket. And if you have that traditional health worker kind of categorization, you can certainly charge to that. But is there another category we can plug into there to satisfy these? Because I just fought to try to get respite, post-hospital respite care, and it looks like that's going to go through. But there are all of these things that are happening. Yes. Oh yeah, I haven't really even told Anita yet, but I know she knows that I've been working on it. But yeah, we had to go through like several channels because their health evidence review commission is like, that could be covered under palliative care. I'm like, yeah, there's no CPT code. So, yeah, sure, we can put a diagnosis on there, prescription, whatever, but you still can't charge to it. So we fought to get it put back on the ILOS request. So maybe there's an avenue there. So if you lean on the OHA side, and we can try that as well. I'll talk with our behavioral health director too. But I just wanted to point that out, that there may be some avenues now that there weren't before. Sorry, Barbara.
This is the magic of connection making, and I really hope that Melissa and Carla and all of your great teams can work to get Jessica's time billable, because that work is helping folks. So love this synergy. Thank you for bringing it up, Carla.
Yeah.
Barbara, go for it.
Yeah, thank you. And Melissa, no, I'm glad that you chimed in on the follow-up. I wanted to say thank you to Carla and Jessica for providing this overview of what the community health centers do. I'm taking part in a subgroup of H.O.P.E where we are looking at trying to use the data from the CSC and the community health centers and Samaritan Health, and looking at the usage of services for medical as well as for sheltering and other services. And we're hoping that will get funded through the SHARE initiative at Samaritan Health. I know Polina Kaiser has reached out to Chris Campbell. So I would encourage you to reach out to Chris Campbell and make sure he gets in contact with Polina, because we do need this information. And hopefully we can get the funding streams so that Jessica's time is billable. Thank you.
Yeah, thank you, Barbara. I think one of the, what I've been trying to advocate over years is to look at this model differently. We can't continue providing this great service in our community for this vulnerable population if you're going to look at it as a traditional health service. Your normal billing processes are not, I can't make it sustainable with normal billing processes, your traditional billing processes. So yeah, Chris actually is one of my employees, so I will make sure to connect with him and get him to be working with Polina.
Yeah, and it's just, when you showed the slide of the reduction in emergency room visits, I mean, that should pay for Jessica's time right there.
I totally agree. And there's, other data around prevented inpatient stays, and, there's all kinds of other, when you think of her story about our patient fakely named Joe, that there's all kinds of other high cost services that have been prevented in this low cost service that's higher cost than your regular primary care visits.
Do we have one last question from any of our board members? I know Dr. Michek needs to exit right at 5. Andrea Myrie, I know you have had questions in the past about how to connect some of your clients with Dr. Michek's services and complex care coordination. Did you have any questions after hearing this presentation?
No, we're already talking with these guys about working together at 3rd Street Commons and in other ways too, and we work frequently with their team. But I would just echo Carla's concern. I mean, that's the same problem that we have with working with people in case management, because it's in housing case management. So, you know, it's okay that there are a number of us doing this kind of work, because everybody appreciate the more help we can get, the better to get people into housing and keep them in housing. But it's super difficult to pay for. Like, we can't, you know, we're training our staff as community health workers. It's not a great fit. We're kind of in the same boat where it's just, you know, the type of work that we're doing it's not a perfect fit with community health worker sort of job description. But right now there's really not another option for us. So we, you know, and it's, I hate to describe it in that way, because community health worker, that work and that development in our state is so significant and special. And I don't mean to, you know, say, oh, we're just going to do this, but it's a way for us to provide that service, because otherwise it's just really difficult. It's it's grant funded, which is not sustainable. So yeah, just echoing Carla.
Yeah, I have about 28 community health workers that I'm still trying to figure out how to sustain without grants. So if you know the recipe, let me know, Andrea.
Well, thank you all. Any last question from our board members? Well, Carla and Jessica and Dr. Michek, thank you for being here and for sharing this information with the whole community and with the Hope board members and answering questions. Please send me those slides and I'll include them on the Hope website. You're getting applause from folks. The work you're doing is amazing. And Jessica, I remember meeting you for the first time at Samaritan Homeless Resource Team in fall 2019. We were both like, we've been here for 2 months. Melissa, did you want to chime back in again?
I have one more maybe hopeful thing. We just got word today that OHA got their 1115 waiver approved. And so more social determinants of health money coming. And I did hear just a little bit ago that there is, that how it gets down to us is the question as a community. So fingers crossed, it's a nice process. But what I did hear is there will be a separate financial bucket for those types of services. And so that may be also a little avenue for us to cover some of these things that have been largely unfunded, but align were not for explicit language that's erroneously used in regulations, right? So I think a lot of promise coming forward.
That is the best news I've had all day. Yay for folks who don't know what
like, oh yeah,
an 11. Yeah, for people who don't know what an 1115 waiver is, the federal government is going to let Oregon waive some things in federal Medicaid law so that we can fund stuff here that typically they don't let be funded, but pretty much every state has a waiver that lets it be funded. And so we finally got approved to get funding for some things that might not be funded without this waiver being approved. So it's really exciting.
Right. Yeah, thank you. That's a good description, an easy way of explaining the 1150 waiver.
Good job, team. Good job, team.
Yay.
So thank you very much for having us. Thanks for the applause. I think I'm going to get kicked out of this conference room. So have a great night. And again, thanks for having us. I'll send you the slides. Thanks, Dr. Michek and Jessica. Have a good night.
Thanks you
to
all.
the three of you. All right. Well, shifting gears. One last caveat, there's multiple 1115 waivers. So there's an 1115 waiver for substance substance use disorder treatment. There's one for other things. There's different types of 1115 waivers. So if you hear just 1115, there isn't just one. There's lots of different types.
Yeah,
Okay,
so a couple of 1115 waivers, and then the other waivers have different numbers depending on what Medicaid regulations they're waiving.
1915A,
It gets complicated really
1915B,
quick.
behavioral health. Yes, it's a whole level of expertise. So thank you for working on it, Melissa. We need that funding. Okay, I'm going to go ahead and screen share again, and we will segue over to some community updates. The first two are really just heads up on a couple of opportunities. The Street Outreach Response Team, SORT, is going to have a wisdom panel to talk about experiences from doing street outreach. And Maddie Bean, who you heard from, I want to say in June, helps organize that. So if you're interested in that, let me know and I can send out the info via email. And also the OPHA, the Oregon Public Health Association Conference, is right here in River City. It's right here at OSU in mid-October, 2 days, and we have a fantastic keynote speaker, Marisa Zapata, and she's going to be giving a keynote on housing really ends homelessness. So if you're interested in that, I will share that information via email too. And I'll go ahead and stop screen sharing because Ricardo has a wonderful update about some housing development, specifically to help folks who work in agriculture. Ricardo, it's all yours.
Yes, thank you very much, Julie. Yeah, just to say that a couple of, on the day that we had the last meeting, the Farm Worker Housing Development Corporation inaugurated Colonia Paz. Colonia Paz is a housing development that is made up of two phases. Phase one is already built, and that is for farm workers exclusively. And phase two, and that one has, I believe, 23 apartments. And then phase two will be inaugurated either later this year or early next year, and that is much larger and has and it's not exclusively for farm workers. Now, Casa Latino Sonidos has a partnership with the Farm Worker Housing Development Corporation, so that we provide wraparound supportive services to the residents of that housing development. But of course, not only the residents, we also, by being there, physically there, we can also provide wraparound support services to the larger community in Lebanon and Sweet Home, this Lebanon and Sweet Home area. So we are extremely happy with that partnership, and through that partnership, we have been able to do things already. In fact, we collaborated with CSC a few months ago and Linn County Public Health to have a health fair that we did at that housing development, Colonia Paz. We are now engaged in another project that is going to be a rapid community assessment, also of the farm worker community. And in general, I would say that this provides a great opportunity, not only for us, for our organization, but for all of our partners who work with us to reach out to the farm worker community in better ways. We are also partnering specifically with Benton Health Department for OHP enrollment there. Although our organization is now going to be able to do OHP enrollment as well. We got support from OHA for that. Yeah, so this kind of area of work, working in housing development, is something very promising for us to support housing developments through wraparound supportive services. So we welcome also any opportunities to do that in Benton County in the future. So we can talk with anyone. And in fact, Andrea, I think we have been in contact about that already.
We welcome it too, Ricardo, please.
Thank you very much. Thank you. And just one thing, and we have a community health worker who is working there at Colonia Paz. Thank you.
Oh, that's amazing. Such fantastic work. Any questions for Ricardo? I put a couple of links in the chat to some press about Colonia Paz, so you can see some beautiful visuals of what this place looks like.
It is beautiful, I should say.
And that's great news that Casa Latinos Unidos workers are now going to be able to enroll folks in OHP. I hadn't heard that yet, so congrats.
Yes. We got a support through Healthier Oregon, so we are going to be doing that.
Can you share with folks who might not know where the actual physical locations for Casa Latinos Unidos in Benton County are?
Yes, we are at Garfield Elementary, room 1. So in the parking lot, turn left, the first room on the left side. There's no need to go through the school, just knock the door, or maybe the door will be opened, and just go on, and we will be happy to receive you there. Yeah, so that is one. We also have a partnership with GAPS. So we have a community health worker place at the Welcome Center in Albany. And the
GAPS is the Greater Area Albany. What is it?
Greater Albany Public Schools. Yeah, so that's a new partnership. So one of our team members is located there. And the third one is Colonia Paz in Lebanon. But our main office is at Garfield Elementary.
Do you still have a location over next to Adams Elementary School?
No, that location, that building is in, they are working on that. So we were asked, we were moved to Garfield Elementary. Which
so
is
relocated at this point.
Yes, and that is a wonderful location for us because we are working very closely with the families from not only Garfield Elementary, but from that neighborhood.
It is. I walk past that almost every day. It's a great place. Well, thank you, Ricardo. Any questions from fellow board members about the great work they are doing? And Peggy, I saw what you put in the chat, just applauding you, Ricardo, for all the great work that you are doing in partnership with so many other folks.
Yes, we always welcome partnerships, so just feel free to get in touch with us. Thank you.
Okay, well, thank you, Ricardo. I'm not seeing any questions from fellow board members, so I'll go ahead and move on because there's a couple of other community updates for today. My wonderful colleague, Brigitte Olson at the City of Corvallis and Paul Bellata too, put together a couple of visuals to document the added shelter capacity and affordable housing in the pipeline. And it was shared at the joint elected official meeting, a couple of weeks ago for the City of Corvallis and Benton County Commissioners. So I wanted to make sure to share it here tonight for the H.O.P.E board members and anybody else who's tuning in. So you can see the added sheltering capacity where we started in 2019 and where we are now in 2022. And it pretty much lines up so you can compare and see that Jackson Street has added units, community outreach has added, Unity Shelter at Room at the Inn, the women's shelter. The men's shelter is not at capacity right now, still because of COVID, and also there's other options now. Unity has added many micro shelters at I think 5 different locations, maybe 6, and then Budget Inn, the 3rd Street Commons, that Corvallis Housing First and Unity Shelter are supporting in partnership. So good news on some added capacity. And then for the more permanent solution to folks experiencing homelessness, affordable development. And so at that 3rd Street Commons location, congrats to Andrea and your team and all of your community partners. There will hopefully be about 40 units of permanent supported housing on site at that location, and they are in pre-development now. And then Paul and Brigitte's team with the City of Corvallis have worked very hard to support and recruit and help finance affordable housing in Corvallis. So you can see it totals 338 affordable units in the pipeline, some under construction, some already financed, and Sycamore Place is already a location that's in operation. And then the South Corvallis Community Land Trust will be working on 11 affordable homes for home ownership, not for rentals. I wanted to go ahead and share that because good news is great in this topic. I'll stop for a second and see if there's any questions about that. Okay, I'm gonna segue to a couple of city and county updates. So the city and the city and the county are embarking on the pilot under HB 4123 to better coordinate the response to homelessness. And so my county colleagues and I are doing outreach to rural cities in Benton County, not just about this pilot because we want to coordinate more, but also because we are looking to update a county code section by removing a sunset date. And so we are doing outreach and engagement. We've met with the Paloma City Manager and the Monroe City Manager, and we are scheduling to meet with the Adair City Manager to really hear feedback from other parts in Benton County outside of the city of Corvallis. What are the communication needs? What are the rural perspectives? And also moving on to engage service providers and religious institutions and other community partners to hear their feedback on this county code and on how we can engage and communicate and coordinate more moving forward. Any questions about that, the outreach to rural cities in Benton County? I'm not hearing anything, so I'm not going to stop screen sharing. The other update, I believe that I've talked about this before, but we are now finally officially a go. There's an organization called ROCKET, and it stands for Resource Organizer for Communities KIT. It helps a community chart a path to solve local challenges. And ROCKET is going to be supporting us for free. Their work is subsidized with a private grant to help us work towards implementing an effective coordinated entry process so we have better data, so we can prioritize our most vulnerable folks when housing becomes available. And we're all pretty excited to have some extra added support. And as far as what's the deliverable, what's the value added from going through this process, it'll be over the next 90 days, so October, November, December. We'll work with our provider partners to create an asset map where we look at assets and gaps. And then we have action items that come out of it, and they will give us hands-on help in facilitating through that whole process to come out the other side with some action items to work towards a better coordinated entry process. So I will stop screen sharing for a second to see if there is any questions about that ROCKET process before I hand it over to Peggy. Just for some background, we have met with other counties that have been through the ROCKET process for identifying resources for folks experiencing homelessness, childcare options, how to do a planning process similar to how the Hope Board was created. And all of the counties we've talked to have said it is so helpful. It builds relationships. It really helps to identify what are the actual tangible barriers and assets and line them up and come up with action items to move something forward in an implementation way. So I'm thrilled to be a part of it. Okay, Peggy, I will go ahead and screen share. Peggy is going to touch upon CSC's role in this topic of coordinated entry that you've learned a lot about. So Peggy, take it away.
Hi, folks. Sorry to cause a little delay. I was just responding to somebody in the messaging. Julie, do you want to go ahead and move forward? This is just my contact information if you'd like to reach out to me. I wanted to just share a little bit about Continuum of Care, and then as we move through this, I'm going to explain why I'm sharing this. A lot of people don't really understand what a Continuum of Care is, but it is an entity that is really, the intention is for it to be a planning entity to create a systemic response to homelessness in a community. And HUD created a requirement for communities that are receiving their funding to have a continuum of care. And this goes way back to 1994. Before then, it was kind of a little more ad hoc. You applied for funding, you got funding, but HUD really wanted to drive the process to everybody coming together and talking about how they were going to end homelessness. And then it was reauthorized under the Hearth Act and other subsequent legislation starting in about the 2010s and going forward. So what is a continuum of care? Who belongs to the continuum of care? Generally, it's community action agencies, public housing authorities, behavioral health providers, veteran service providers, including county veteran service officers, culturally specific service providers, so organizations like Casa Latinos and NAACP and some of the other folks that we have locally, shelter providers, affordable housing developers, and housing and supportive services providers. And the idea is that you bring everybody who has anything to do with the entire continuum of working with people from being unhoused or precariously housed all the way to purchasing homes. And everybody's able to sit around together and have a conversation. Go ahead and advance, Julie. And so who governs a continuum of care, which by the way is abbreviated COC? You probably figured that out from my slide. Municipalities sometimes govern a continuum of care. Community action agencies can govern a continuum of care. Nonprofit service providers. The idea is that each community and community will, I'll get to in just a second, will decide for themselves what kind of structure they need and what that should look like. And so what is that geographic makeup? It can be a city, it can be a county, it can be multiple counties, it can be an entire state, it can be a region. The continuum of care that we belong to in Benton County is called the Rural Oregon Continuum of Care, or ROCC, ROCC, and I'll get to that in a couple of minutes too. What is a continuum of care responsible for doing? The idea is they're going to do the homeless response systems planning, homeless management information system oversight and reporting. Every coordinated care organization or continuum of care organization has to have a homeless management information system for reporting. And this homeless management information system has to be approved by HUD. So across the nation, there are dozens of different systems. We use a system called WellSky or Service Point here in our area, and that's dictated by the ROCC and dictated by the state of Oregon through Oregon Housing and Community Services. There was the coordinated continuum of care. Wait, go back one more. Continuum of care is responsible for the coordinated entry and assessment process that a community uses. They're responsible for data gathering and analytics through that HMIS system. They're responsible for managing the annual point in time count that is required by HUD. And that's the point in time count of people who are unhoused. So that's both people who are staying in shelters, plus whoever we can find who are camping and sleeping out rough in the community. It does not include people who are doubled up. So if families are staying together to be able to remain housed, those folks don't get counted as being unhoused. It's only people who are in cars or camping in areas that are not meant for human habitation or literally living out in the open. And the coordinated care, Continuum of Care organization is also responsible for competing for funds for HUD for a particular area. Now we can go ahead and advance. So the ROCC, as I mentioned previously, is considered to be the balance of state continuum for Oregon. And you can find information about it on oregonbos.org. And here's a list of all of the counties that are in that continuum. So 26 different counties, and you can see they're quite disparate counties. So we think that there's a lot of variation between Linn, Benton, and Lincoln counties, which are the three counties that CSC and the COG serve, and other entities that you may be familiar with in our area. Imagine we belong to this group that covers all of these counties. So what does CSC currently do that is required by a continuum of care? We provide the HMIS oversight. We check all the reporting to make sure it's accurate. We do training of the entities that are putting data in, and then we report up to the ROC, and that gets rolled up to the state level, Oregon Housing and Community Services, who rolls that up to the federal level at HUD, and then Congress gets an annual report every year from the information that's in that HMIS system. CSC also does the point in time count coordination for that count across the Tri-County region. We manage the coordinated entry list, and I'm going to talk a little bit more about that in a second for our region. We also manage the veteran by name list. So there's a separate homeless veteran list, and we do coordinated or continuum of care project oversight. So there are a number of different continuum of care funded projects that CSC oversees, and that funding comes to us and we report on the activities that happen in those housing units. Okay, we can roll on a minute. So that coordinated entry, coordinated assessment system that is required by HUD includes the idea that we will allocate assistance in the most easily accessible manner. So we're trying to get everybody who is unhoused into a list, and that list should prioritize them based on their vulnerability and the severity of their service needs. So we do what's called a vulnerability assessment. There are approved tools that we can use. The one that the ROC has chosen for all of its member counties to use is called a VI SPDAT. And I know that just rolls off your tongue. What that stands for is Vulnerability Index. Can't remember what the SP is, but it's a prioritized decision-making tool. And we can also, in that prioritization process, have subpopulations that are separated out. So we recognize that youth and veterans and people who are fleeing domestic violence might not all be good populations to be lumped together to select from to put into housing. We may want to have separate housing for those different populations. So that process does allow us to do that. Okay, Julie, a little bit more. A little bit of the basics on coordinated entry. We are required to include stakeholder planning and consultation to make sure that we have a process that works well and is accessible to the people who are trying to use it. And that's one of the things that Rocket is going to be helping us look at. We have to use that homeless management information system that is dictated, in our case, by the ROC and by the state. It defines central prioritizing principles. So we can say, well, in our community, we want to have these certain principles. We want to do housing first. We want to do, whatever, give some particular type of process improvement piece that we want to include. But again, the continuum of care dictates what that is. We don't get to dictate that locally. And it also keeps people who are really, really vulnerable from languishing in shelter. At least that's the theory, that if you're very vulnerable, you're going to be able to access the first available housing. What a lot of people are confused about, though, is they think of this as a waiting list. The coordinated entry list is not a waiting list. It ideally can help you identify every single individual who is unhoused and needs housing in your community. And there is just absolutely not sufficient housing to ensure that all those people are housed. So sometimes people will say, oh, I'm number 85 on the list. That doesn't mean that there's, like the Section 8 wait list, there's 84 people ahead of you to get housing. You could stay on that coordinated entry list literally for a lifetime. All righty, let's move forward. I also want to say that not every housing provider enters their information into the homeless management information system. The only people who are required to do it are people who are receiving HUD funds. And oftentimes, because this is an extra burdensome process that needs to be done, if people aren't getting paid to do it, they may not choose to do it. We locally have talked about the VI SPDAT. We feel, and social scientists across the nation verify this, that it is not an equitable tool, that it leads to a coordinated entry list that prioritizes people in a disparate way, so that individuals who are Black and brown are disproportionately lower on the list and less likely to get housing. But again, the ROC dictates which list we use. We manage at CSC the HMIS system. Again, I've mentioned that. One of the things that HUD has recently encouraged, and we really want to do in this community, is do case conferencing. So as we look at the people on the coordinated entry list, a group of providers would like to come together and say, here are these 5 people, here are the special needs that each of them have. Let's talk about who can take on what piece of a situation in their life to provide supports that they need to stabilize them in their housing and make that a successful option for them. We're still trying to figure out exactly what that case conferencing process will look like, who will participate, and how it will take place. Service Point, again, is the HMIS system that we use. It does not interface with a lot of systems that other folks are currently required to use. So if you receive funding from IHN-CCO, you are required to use UNITA. Service Point does not interface with that. If you're using both systems, you would have to put information into both systems. I whine all the time at my agency. We have over 40 systems that we put information into that our funders require, and they do not interact with our HMIS system. One of them is an HMIS system, but the others are completely separate. So having our own continuum of care would really allow us locally to make a lot more decisions that would allow flexibility, would allow us to be more nimble, and would also be more equitable in the outcomes. So we've been having those conversations internally, and CSC, who has kind of the unofficial designation of being the manager of the continuum of care process for our area because of the funding that we're associated with. And we speak out at the ROC on behalf of the community, and we participate in the ROC decision making. My housing services manager is on the executive board of the ROC. So you can imagine we try to influence a lot of the decisions at the ROC, but with 26 counties, we're not always successful. So we have been talking at CSC with our governing board about pulling out of the ROC and forming a Linn, Benton, Lincoln continuum of care. Julie, I can't remember if I have another slide after this. Oh, nope, not. Thank you. So what I wanted to say about that is it's not cut and dried, it's not cast in concrete, but our governing board, who are the county commissioners of each of the 3 counties, met yesterday and gave me permission to go ahead and develop a proposed plan for what it would look like to pull out of the ROC and form our own continuum in Linn, Benton, and Lincoln counties, what the budget would look like for that process, what pieces CSC is already doing, and what we would have to add to be to fit the HUD requirements of being able to do this. And so I just wanted to put that out there in the community, begin talking about it, because you're going to begin hearing about it in circles like this, where we're beginning to say, what would it look like? What kind of control will it give us? And who's going to take responsibility for the different pieces? So Julie, I'm not sure if there's any questions or if there's anything else. Oh, Melissa, thank you. Melissa Egan, one of my amazing staff members, put VI SPDAT is Vulnerability Index Service Prioritization Decision Assistance Tool. Fancy. Just means it helps us figure out who's most vulnerable. So happy to answer any other questions. Also happy to answer questions offline. You have my contact information.
Peggy, one question that I got asked, and I only know one example, so I wanted to ask you, do we have local providers who have missed out on opportunities being part of the Rural Oregon Continuum of Care that might be able to apply for HUD funding if Linn, Benton, and Lincoln were our own Continuum of Care?
Yeah, thank you very much for asking that, Julie. That's a really important question. Recently, Jackson Street Youth Services wanted to apply for Runaway and Homeless Youth funding. HUD almost never offers you new funding opportunities under Continuum of Care, and they suddenly came out with a Homeless and Runaway Youth opportunity. And again, this is a national competition that we go to. And Jackson Street, who could very well have competed very well in that process, and likely been successful at getting that funding, was told by the Rock that no, the Rock was not going to apply for those funds, therefore Jackson Street could not apply. I see Andrea's got her hand up as well.
Oh, Peggy, I just wanted to say thank you so much for this overview. It answers so many of the questions that people have had about this and makes it clear, sort of a path forward. And I just really appreciate all the information because it's becoming a little clearer now what's going to happen. So thank you.
Awesome. Well, and Andrea, thank you for your continued participation. I know that you knock yourself out to be part of the Rock so that our local voice is heard from more than just CSC, and I really appreciate that as well.
Yeah, Andrea, I don't know if folks know that you're on the board or how you interact with the Rock. Can you describe that at all?
No, I just resigned.
Or previously to now.
Because they always have meetings when I have other things going on, and but we did just along with the CDDC, we applied for the funding that that Peggy was just talking about. That was unfortunate that was communicated wrongly to Jackson Street. So so I don't know if we'll get that, but we'll see. So we may be participating in that extra funding through HUD.
Best of luck to you. Any more HUD funding we can bring into the community would be great. Peggy has also done a lot of work to reach out to our colleagues in Marion and Polk counties who also withdrew from the Rural Oregon Continuum of Care about 2 years ago. And so learning from their experience, what happened, what did it take, what was the timeline like, did you lose funding? They did not, they added funding. So she's not reinventing the wheel. She's also taking good hints from a path that has already been blazed and seems to be a benefit added to the community. So if you have any more questions about that.
Yeah, thanks, Julie. Just one other quick comment about that. My colleague, Jimmy Jones, who's the executive director of the Mid-Willamette Valley Community Action Agency, and just a wonderful guy and somebody that I've known for quite some time, and we have a great relationship, is more than happy to be our mentor on this process.
Well, and I wonder, Peggy, if there's a role for the Hope Board to play maybe this winter or spring or whenever it seems timely to provide feedback or to talk about the timeline or the process or ask questions. Just
absolutely. I think that definitely to provide feedback on the timeline. We have just finished the national competitive process. It's never exactly sure when HUD is going to put out these competitions, but they're roughly a year that passes between them. And so we figure if we start this process now, we should be ready and able to compete as the Linn, Benton, Lincoln Continuum next year when the funding comes available. And so we'll have a lot of opportunity to do that.
Thanks, Peggy. Any questions from folks? A couple things to note before we move on. Paula, Catherine Bisco is attending as the phone number. Since you can't see the chat, you did not see that update, but Catherine is here, and so is Bria. Wanted to make sure you saw that. And then I thought Ben Danley was here. I was going to ask if he had an update, but I don't think he is in the meeting anymore. So
Ben Danley was definitely here.
He was. Okay. He's shared this publicly, so it's not a surprise. But he is moving on from being the executive director at COI. He will still be their director until the end of October for 1 more month. And then he's transitioning on to a different career path. And we are just going to miss him dearly as one of a key provider partner in this community. So if you have the opportunity to reach out to him and thank him for years of working at COI, please do so. Okay, well, we will move on to the next part of your agenda. George, I see you're here. That's awesome. Let me bring this up. George, as one of the HOPE co-chairs, is going to talk about what has happened with him and the city's task force. Go for it, George.
No, thanks. So just a quick update that Bria and I met with Paul Bellotta and Brigitte Olson and Paul Schaefer last 2 weeks ago. That's just to let them know that the Hope Board was ready and available to assist them in any way with the process that they're engaging in to revise their social services policy with the city. I attended their first meeting. The meeting we had with them 2 weeks ago was the day before the first meeting, so I attended and listened to the first meeting. They're aware that we're here and that we're available to assist them in any way that they see fit to use us, and we may well hear from them. And I was going to say, I don't know if Jen has anything to add to that, but essentially we'll wait to hear from them at this point in time to see where they want to go. And I'll be having coffee with Paul Schaefer next week just to have a little more detailed discussion.
Thank you, George. I also included for folks the spectrum of public participation. I think the task force landed on consult. Do I have that right?
Yeah, not sure. That would be a Jan question.
Jan, are you able to chime in and talk about what's going on from the task force perspective?
Right. So we actually have had 2 meetings. No, the first one wasn't an official meeting. There were only 3 of us. What we've come up with is a path forward. We're going to be interviewing or surveying, not interviewing, surveying providers. We are collecting some information that is, we want to make sure that we are hitting all the providers. And so there is some HOPE data that's being resurrected. Thank you very much in aiding our on where we're headed. So our next meeting is, I believe, I think it's the 12th. You can check in on that. Then we're going to have 1 meeting in November and 2 meetings in December. We should be finishing up by the 31st. And that's about all what we have. We have the list of questions put together for our providers. And we have been conferring with Brigitte. So facts and figures at this point.
Thank you, Jan. When you first had met, you had talked about utilizing a HOPE board meeting, not specifically just for feedback from the HOPE board members, but also as a public forum to get any kind of public feedback in a transparent, publicly noticed meeting type way for whatever the task force wants to learn or get feedback from. Is that something that you haven't decided yet and you'll be talking about going forward?
Well, because we have, I did put that forward. It didn't gain a lot of traction, but it's still early in the process. And I'm thinking that, what they want to be sure that this is how the social services money that goes from the levy is being spent. It's not the grant money from the block grant. And this amounts to about $380,000. So we're looking at that in how, if HOPE is involved, we've got the 13 recommendations. If that can interleave with what we hear from our providers, we'll certainly take that into consideration. Correction, the October 5th, 4:30 is our next meeting. And that'll be noticed, and you should be able to join in on that and listen in. But for now, I think we're just we're tabling the concept of having the HOPE board chime in until after we get information from our providers.
Thanks for the update, Jan. Any questions for Jan and George about this topic? Okay. I'll go ahead and move on. I also included some links from Paul Bellata. If you're interested in more information about what this city task force is doing, you can sign up. You can first go to the website where it gives more information, and then you can also sign up for updates on the process. The city has a way to stay connected on a variety of different topics, so you would check the box for this specific one in addition to any other topics you want to learn more about, and you put your email in. So some next steps for upcoming HOPE meetings. The October meeting is normal, the same, fourth Wednesday of the month, October 26th. Based on the federal holidays and kids being out of school in November and December, I sent out a poll to all of you asking which dates would work in November, either the second or the third Wednesday of the month instead of the fourth. And you will have a quorum on these two dates. So your November meeting is going to be on November 9th. It's the second Wednesday of the month. And your December meeting is going to be on December 14th, also the second Wednesday of the month. Real quick, I'm going to stop screen sharing and ask if those dates work for a couple of other folks who are joining tonight. If I could make sure to have Brian and Melissa and Bria confirm that those dates do or do not work for you, and shoot me a quick email to make sure that I know who can make it on which day.
What are those
I know
dates
that
again, Julie?
November.
Hold on just one second.
Sorry.
I'll go ahead and pull it right back up. Brian, you were going to chime in with what were you saying?
I'm good in November. December 14th might be in question for me.
Okay, Brian, you're good November 9th. Thank you. Go ahead, Melissa.
November 9th is the better date, but I could do the 14th.
No, this is
December.
this will be for the November meeting and then separately the December meeting. So your November meeting will be on the 9th instead of the last Wednesday.
Right.
And then the December meeting will be the 14th. Okay, so you're good for November 9th?
Yes.
Okay, but December also is a maybe or a no.
I could make it work.
If you can, that's the date that has a quorum, not the other one.
Okay.
But you will have a quorum for that December 14th date. Thank you for chiming in. Just for going forward this fall, I touched upon we're going to be working to move forward the pilot for coordinated homeless response and doing outreach to our rural Benton County partners. And we're also going to be working this fall to improve our data and work towards an improved coordinated entry system in partnership with our providers. It's going to be facilitated by Rocket. So I will stop screen sharing and see if there's any questions about any of that. All right. Well, any other updates from board members that you would like to share? This fall, there are a couple possibilities for engaging the HOPE board in some community feedback. So I'll be working with the executive committee on what they would like to plan for agenda setting and also with a couple community partners. And one of them is Allison Hobgood, the executive director with the Daytime Drop-In Center, and she touched briefly upon the drop-in center's goals to expand and have an improved site to become a full navigation center that has on-site resources from different providers and places for people to stay who are experiencing homelessness. And so it might be the right time for her to come back to the HOPE board sometime this fall and really engage you and hear your feedback on this concept and this idea, because a navigation center implements 4 of your different HOPE recommendations for data and care coordination. I got muted. Sorry, folks. So that's one possibility for this fall, and your participation and engagement and feedback and questions will be very helpful. Another possibility this fall is the Justice Systems Improvement Project, which includes the Crisis Center. Cindy, you're giving me a face like you've never heard that term before. Ask a question.
I was making that face because of the map that I saw of the new Justice Center with the
Mhm.
jail and this big, huge block of housing?
Oh, that term are the jail cells. So in justice system work, the quote unquote housing is where folks who are in incarceration are being housed, or people who are awaiting
Okay.
pretrial. It's a justice system term of like the housing for
Okay.
the justice system, but that is confusing terminology, and I believe that map is being updated because of
Good.
that confusion.
Good, good, good. Because we have a city councilor who
Nope, Cindy, you just cut out for me. All I heard was city councilor who.
I a city councilor who thought that that's what it meant, that it was going to be housing for people. So I will let that person know that that's not the case. Thank you.
And that would be the reason for a public interactive question and answer, to be able to show those visuals, hear your questions, clear up confusion, and then also really highlight what is a crisis center. How is it separate and distinct from the navigation center concept that the daytime drop-in center would like to move forward? And to really hear your feedback and questions and engagement, because crisis response was one of the HOPE recommendations that you all passed on. Yeah, George.
Oh, no, I had nothing. That's...
Oh, okay. So those are some ideas for this fall, or possible engagement on this city social service task force process. We will wait to hear more on that. So it will not just be education this fall. It will be really needing your feedback, engagement, questions, and vetting of some ideas. So I'm excited to be able to bring some of those to HOPE meetings this fall as the HOPE Executive Committee decides on their agenda setting and when happens. So. Any questions or last minute thoughts, folks? Well, thank you all for being here tonight. George, did you have anything else, or Bria, as our co-chairs, that you wanted to say?
No, thank you all. Just thank you all for attending. Always good to see you.
Good to see you all. Thanks for being here tonight.
Thank you so much.
I'll
Bye.
talk to you guys later. Bye.
Bye.
Thanks, everyone.